yes. So hello, everybody. So welcome to our webinar on genomic testing and thalassemia. So I'm Emma Matthews. I'm a consultant neurologist at St. George's Hospital, but I'm also one of the rare disease leads for the Southeast Genomic Medicine Service. So it's this hat that I join you with on this webinar. And we started this webinar series because approximately 75% of rare diseases do have a genetic basis. But we realized that people with rare genetic conditions, they don't tend to present themselves to a specialist and say, hi, I have a rare disease. They're far more likely to present through frontline NHS services and general clinics, and often to have many contacts across the NHS before a diagnosis is made. So one of the aims of our webinars really was to try to take different topics and hopefully provide some further information on which patients that you might see amongst all of your patients, which ones to consider genetic testing in and when to do that, and a little bit that we'll run through in a few minutes on how to do that. So today we're focusing on thalassemia, and I'm very pleased that Dr. James Masters, who's a consultant haematologist at George's, is going to talk to us in a few minutes on that. But we like to start the webinars just with a brief introduction to how genomic testing is currently done in the NHS and a few pointers on this. Now, I appreciate for some of you, we have a mixed audience, so some of you may be very familiar with this already, and I apologize if I'm going over things you already know, but for some of you, this may be completely new. So as I say, it's a brief introduction, and then I will also signpost to other resources for help for those of you who would like to know more. So I'm just going to share my screen. So, and I should just say, Carmel and Lauren are here from the education team from the Southeast GMSA. So I'll just check in with Carmel. Are you seeing my screen okay? Yeah, perfect. Okay, so as I say, this is a very brief introduction to genomic testing and the genomic medicine service as things currently stand in the NHS. So the genomic medicine services, they really come about in approximately the last 5 years due to some heavy investment from NHS England. And all of the services, they have two main partners. So they will each have a genomic laboratory hub, the laboratory obviously being where all of the tests are sent, the analysis is done and reports are generated from. And these are partnered with the Genomic Medicine Service Alliances. And the GMSAs have more of a role in education and in supporting what NHS England like to call mainstreaming of genomics in the NHS. So in the past, a lot of genetic testing was perhaps done in specialist clinics or tertiary centres or by our clinical genetic colleagues and services. Now, I should say that clinical genetic services, of course, they still exist and are still very integral to the medicine service overall. But because the amount of genetic testing that is available in the NHS now has increased exponentially, and obviously it's NHS England's aim that patients don't necessarily have to wait or be referred perhaps quite far away from home for all their genetic testing. They want a lot of it to be embedded in general neurology services so that patients, no matter where they are, if they're eligible for a genetic test, can have a genetic test. So the clinical genetic services, they can't incorporate all of that work, but they do still very much exist and are available for advice, guidance, education, and obviously do still see patients, particularly at the more complicated end of the spectrum. In the Southeast GMSA, their lead trusts are Guy's and St. Thomas's and St. George's, but obviously we serve all trusts in the region. And in recognition that, this is really a large and new area of medicine to many people, NHS England do have a big genomics education programme that is mostly web-based, and there is in collaboration with the research team as well. So as I say, there are 7 genomic medicine services across England divided geographically. So we sit in the southeast, and each of them consists of a genomic laboratory hub and the Genomic Medicine Alliance. And essentially, they've been set up in this way so that all hubs will operate to the same national guidelines and standards. And the idea, as I say, is to improve equity of access. So no matter where you live, you can have access to exactly the same genetic testing and input. And all of the services deliver genomic testing from this thing called the National Genomic Test Directory. So the test directory is essentially a list of all genomic tests that are now available via the NHS. The eligibility criteria, so who is eligible to receive these tests, and the technology used to deliver them. So you can scan the QR code here. It will take you to the website where the National Genomic Test Directory is available. When you go to it, there will be an Excel websheet version and a PDF version. The PDF is much more user-friendly, so I encourage you to use the PDF. You can download it, you can save it on your own computer to refer to each time if you want to, but it is updated at least yearly. So just at least once every 12 months, just go back to the website and check that you have the current version. And of course, all the tests are available in this test directory, but they're divided by subspecialties. So you often just go to the subspecialty that you may work within. You don't need to know about all of them. And just to say as well, tests are now centrally funded. So in the past, there was quite a lot of gatekeeping from trusts because the individual trust would have to pay for the genetic testing that it did. But NHS England now centrally funds the laboratory. So it's still NHS funded, but as an individual trust, you don't have to be concerned with paying for the test. So in the test directory, you can go and you can find the test that you want. So today we're discussing thalassemia. So you go along, there will be the own page for the thalassemia test. Unfortunately, on the order form, you can't write down, you want to test for thalassemia. Every test has an R number, so you need to find the R number, and that is what you need to write down on the form. Then there will be a little bit about eligibility. Now the labs are pushing back a little bit on this now because in the beginning they were swamped really with a lot of tests, and some of those tests that maybe that the test that was being requested maybe wasn't the most appropriate test for that patient. There may have been a more appropriate one, or it may be that they wasn't really suitable for genetic testing at all. So there will be some checking of eligibility, and sometimes labs may come back to you for more information. It may suggest a different test as well, depending on what it is you want to know. It will list requesting specialties. So this is by specialty, not individual profession. So within the requesting specialties assigned to a test, that includes doctors, nurses, other allied health professionals, any qualified person who is able to perform the genetic testing. And it will also tell you the method by which the test is done. Now, the reason this is important is because when you fill in your request forms, essentially there are two. So if in the method it says whole genome sequencing, or WGS, it will say for short, then you need to use WGS forms. If it says anything else, so anything other than WGS, is all grouped together as a non-whole genome sequencing or non-WGS test. So here for the thalassemia, it's listed as MLPA or small panel. All you really need to take from that is it's not saying WGS, so you need the non-WGS forms. And on the forms, there will be a section about the clinical information, family history. Again, this comes back to the eligibility. The more that you can put in here, it also helps the lab's interpretation of the test result if they find genetic variants. But again, it saves you being asked for more questions from the laboratory or questioned about the eligibility. So obviously, you have a patient, you think, okay, this is the condition that I would like to test for. You found the R number in the test directory, but you need to discuss with the patient, why you might do this testing, what the benefit of the testing might be for them. And obviously, as we're going to hear from James in a little bit more about thalassemia specifically, it may inform treatment and management, but also a genetic test rarely has implications just for the patient. It does have implications for family members as well. And it also can have implications or offer them reproductive options if they are family planning. So all of these things need to be discussed along with a few other details, and this needs to be documented in the record of discussion form. And as I say, if it is a WGS, if in the method on the test directory it says WGS, then you need a WGS record of discussion form. If it is non-WGS, if it is anything else, it's the non-WGS record of discussion form. and this goes along with the test request form. So if it's non-WGS, you discuss the potential implications with the patient, complete the record of discussion form, and complete the non-WGS test order form. If it is a test done by whole genome sequencing, you can consider a trio. A trio means the patient plus DNA or blood from their parents. That can help again in the interpretation of the results. It's particularly important in the pediatric setting, and I think most WGS tests are done by trio analysis in the pediatric setting. I work in the adult setting, so it's not always essential to have the trio. It's helpful, but not essential, and we do send individual probands. So again, discuss the potential implications, and you complete the WGS record of discussion form and then the WGS test order form. So as I say, this was literally an introduction and an overview. This is not designed to be a comprehensive explanation of how to order genomic testing, but there are many resources available for if you want to find out more. So on our website, there is a section on how to order, how to fill in these forms, how to find the test that you want. I mentioned Genomics England. They also have a very large education program on their website. They have a lot of bite-sized learning. There are short courses. There's even a master's program in genomic medicine or modules that you can choose to do if very, very interested. As part of their program, there is this thing called G-Notes, Genomic Notes for Clinicians. And these are designed, again, by subspecialties. So there's a Haematology G-Notes, and it will take you through clear examples in the clinic. So, for example, if you want to have someone you think they have thalassaemia, it will, again, cover their eligibility, cover the R number. It will tell you which form you need to fill in. It will even tell you what blood tube you need to send. So these are designed to be practical guides written by clinicians for clinicians. And then there are many other resources as well. And just to say finally, so Lauren and Carmel are two of the of our education team. So they do provide a more comprehensive webinar, approximately 45 minutes, guiding through how you fill in the forms, how you look through the test directory. If there are any departments or teams who would be particularly interested to know more as a group, if you contact us in the education team, then we can come and deliver that to your department as well. So as I say, a brief introduction, but I think I've talked enough. I'd say that's an introduction to genomic testing in general. But now I'm absolutely delighted to introduce James Masters, who is one of our consultant haematologists, who's going to take us through genomic testing specifically for people who are suspected of having thalassemia and the benefits of this genomic testing. So thanks very much, James.
No, thank you. Can you hear me okay?
Yes, I can.
Lovely. I'm just going to share my slides. Lovely. Put some slideshow. Lovely. Can you see the first slide?
I do.
Perfect, lovely. Let me know if you want me to slow down or speed up. So my name's James, one of the haematology consultants here at St George's, and I often treat patients who have thalassemia. So I thought today would be a good chance to sort of reflect on the importance of genomics testing in our thalassemia cohort. So I'll go through a brief introduction of what thalassemia is, as well as its clinical implications for patients as well, and then talk a bit towards the end about the importance of genomic testing, especially in the adult setting, which is I'm predominantly an adult haematologist. So I think it's important to look at our definitions first before we carry on. So I am a haemoglobinopathy consultant, and a haemoglobinopathy is a genetic blood disorder that results in any abnormality in the structure or production of hemoglobin. As we know, we're focusing on thalassemia this time, and thalassemia is a group of hereditary hemolytic disorders caused by impaired hemoglobin synthesis. Now, that's not quite true in the sense you can have an acquired thalassemia, so you can get acquired alpha and beta thalassemias, both in the context of myelodysplastic syndrome. I'm not going to touch on those here because that's a very different disease, often associated with more on sort of MDS or myelodysplastic problems, which are often seen by my oncology cohorts, my oncology colleagues, as opposed to me. So a more simplistic way of classifying hemoglobinopathies, and I like to have things boiled down to quite simple things, otherwise I don't understand them, would be looking at quantitative or qualitative problems. And we see quite a lot of both in in our haemoglobinopathy work. So qualitative being the structural problem with our haemoglobin, and that will be things like sickle cell or hemoglobin E disease. But I suppose clinically the ones we see more is our sickle cell population. And quantitative, so not producing enough of particular globin chains, and that's where we're going to focus today, which is our thalassemia cohort. So this is a lovely normal hemoglobin, and I suppose you have to understand normal before we can understand abnormal. And a normal hemoglobin is made up of 4 globin chains, and by vast majority of our hemoglobin as an adult is HbA, which is made up of 2 alpha and 2 beta chains. And in terms of the genes that code them, we have 2 alphas on chromosome 16, and we have 1 beta gene on chromosome 11. We also have a smaller proportion of HbA2, which is formed of 2 alpha and 2 delta chains. But that's not always how things are. And actually, when you start life, you have a very different makeup of your hemoglobins. And the reason being is at birth or prior to birth, the environment at which the fetus is very hypoxic. And actually having hemoglobins that are better managed and better hang on to oxygen in that circumstance is much, much better. So actually you have 2 Gower hemoglobins formed of very different hemoglobin chains. You have HB Portland, but also importantly, and something I'm going to keep referring back to, is fetal hemoglobin, which is composed of 2 alpha and 2 gamma chains. And again, it's important to remember the makeup of those because that's going to become a bit more relevant as I go on through my talk. Now, in the early stages of life, you have these predominantly embryonic hemoglobins, but by 18 weeks of life, actually, you've managed to switch entirely from your fetal hemoglobin production all the way to adult hemoglobin. So about 18, 24 weeks of age, you're producing essentially normal adult hemoglobins, so hemoglobin A and hemoglobin A2. So thalassemia, I think we should say, not common in the UK. And certainly transfusion-dependent thalassemia, so thalassemias that require regular transfusions and are less common. And we have probably about 800 patients across the UK that have transfusion-dependent thalassemia, a large number that don't. But across the globe, they're much more common. And historically, and I say historically because people have migrated and moved, but historically we had various geographical distributions of these. So for our alpha thalassemias, we tend to have deletional thalassemias in sort of very far east, and certainly we do have a population of our HbH patients who come from Hong Kong and areas of China, but also non-deletional from other parts of Europe and Africa. Similarly, your beta thalassemias are quite well spread across sort of Southeast Asia, the Indian subcontinent, into the Mediterranean and into Africa. The mutations that we find here vary depending on the geographical location of where your sort of your ethnic origin. So there isn't really one common mutation that we see because actually they vary depending on where sort of your origins. And so the next thing is, and this relates back to the importance of understanding your genotype, is actually your clinical phenotype will very much depend on the number of genes affected. So looking at beta and alpha thalassemia, I'm going to focus on beta and alpha thalassemia. You do have gamma and delta thalassemias, which are incredibly rare. We don't tend to see, because I don't think they give you that many symptoms. But with your beta thalassemia, you can have thalassemia minor, intermediate and major historically, and that would be classified based on the number of globin chains affected. Now, we actually don't classify them this way anymore because actually the intermediate and major is somewhat unhelpful. We tend to class them as whether they require transfusion or not. So we could class them as transfusion dependent or non-transfusion dependent thalassemias. Our alpha thalassemias, again, sequentially get more severe depending on the amount of alpha genes you're missing or alpha globin chains you're missing. So the first 2, so alpha, so a silent carrier on alpha trait, who are missing just 1 to 2 alpha globin genes, tend to actually have only very mild disease. Well, actually, no, sorry, asymptomatic disease. So they may not know anything, and actually clinically it's probably not very important for them. It becomes more important if they're thinking of having children, because actually depending on what their partner may have, or their prospective partner, it may lead to more clinically significant problems going forward with a potential child. And this is because when you miss 3 alpha genes, you develop HbH disease, which is much more clinically significant. These are patients who often run much lower hemoglobins, may or may not be transfusion dependent, and may or may not have complications of of having thalassemia, such as extramedullary hematopoiesis, osteoporosis. And then you move on to HB Bart's, which is an altogether very different disease where all 4 alpha chains are missing. So if you remember a couple of slides ago, the predominant feature of HbA and HbA2 and fetal hemoglobin is having 2 alpha chains. If you're missing all 4 or they don't work, then actually you can't produce many normal hemoglobins at all, and you end up producing HB Bart's, which is a 4 gamma globin gene. 4 gamma globin carrying hemoglobin, which has a very high oxygen affinity, so it doesn't impart its oxygen very much to tissues at all. Often this presents in utero with hydrops fetalis, with massive fluid overload and cardiac failure. And actually, until very recently, this was felt to be incompatible with life, although there are case reports of individuals living through the early years of their life. So this is sort of a disease we want to try and avoid, especially with our prenatal testing. Now, it wouldn't be haematology if I didn't show you a blood film, because it's what we see all the time. And this is not a thalassemia blood film. This is a beautifully normal blood film. Looking at the red cells here, they're lovely and healthy. They have a lovely sort of 2/3 filling of their hemoglobin. They have that pale bit in the middle because your red cells are a biconcave disc. So we see this pallor in the middle, but these are all entirely normal. They have lovely uniformity. There isn't much else going on here, really. If we compare that to a thalassemia blood film, things look very, very different. You can see there's a huge variety of cells, and actually the majority are very, very small. You have some cells which have very poor hemoglobinization, so have very little hemoglobin in them, so much more white, a lot of which are target cells. And you have these cells with blue dots in them, and actually these are very young red cells, and so these are cells that are being pushed out into the periphery far too early, and shouldn't be there. This patient here has probably had transfusion because there's a number of quite normal looking red cells as well, which I suspect is part of their treatment. Thalassemia has quite wide-arching consequences, and that's because by not producing particular globin chains, do you not only get a reduction of your particular globin chain affected, but you also get an excess of the other chains. And I'm going to focus here on beta thalassemia, just for example. So in beta thalassemia, you have X, so you have a decrease in your beta globin production or a complete deficit, and that leads to an imbalance with alpha globin chains being produced. Now, alpha globin chains on their own can be quite toxic to the red cell, and what this leads to is a period of either unstable red cells, which in the periphery hemolyze and causing ongoing hemolysis, or apoptosis, cell apoptosis and death within the bone marrow, leading to essentially dyserythropoiesis. Now, the consequences is it drives the bone marrow to try and make more hemoglobin, with the body trying to adapt to that circumstance. And you get something called extramedullary hematopoiesis, which is where you get tissues outside of the bone marrow producing, or bone marrow tissue outside of the bone marrow. Often this can be paraspinal and can lead to problems. On top of that, you can get in untreated individuals, and certainly in the past, bony deformities caused by patients whose you have bone marrow expansion, especially across the facial bones in particular, and I'll show a picture in a second. But there are lots of other problems that this can lead to. You can get splenomegaly, and because of recurrent hemolysis, you can get gallstones. On top of this, you can get nephrocalcinosis because of damage to the renal tubules. Ongoing bone marrow expansion can also lead to osteoporosis, but that's also impacted upon by the effects on the pituitary. Now, part of the management, and I will touch on management in a second, of thalassemia is transfusion, and actually transfusing people to a very high level. So we're not transfusing people with HB of 70 as we would do normally in trauma or in A&E, but actually we're transfusing people to over 100. And the reason we're doing that is for a very different purpose. What we're trying to do is to switch off that erythropoietic drive that we've talked about now, which is dysfunctional in thalassemia. And in doing so, we're trying to reduce the complications. However, by doing this, we lead to problems of iron overload. And actually, it's the iron overload that causes lots of other consequences. For instance, it's the iron loading within the pituitary that leads to lots of endocrinopathies. And this on its own can lead to infertility, as well as diabetes and hypothyroidism. You can get iron overload within the liver, which can lead to cirrhosis, as well as the heart, which can lead to a fatal it can be fatal, but also lead to arrhythmias and heart failure. On top of this, you can get an increased risk of thrombosis, not just because of indwelling lines that people may have in order to deliver some of these medications, but also because of the hyperinflammatory state, and it can lead to pulmonary hypertension too. Now, we do have iron chelation agents as well, but these on their own can also lead to lots of complications, unfortunately, which can include renal impairment, can include hearing loss and sight loss. This is a picture of a unfortunate child who's had seemingly extramedullary hematopoiesis and bone marrow expansion caused by thalassaemia. And you can see across the cheeks, you've had this sort of bone marrow expansion causing that facial deformity. And on the left, you can see, or it might be, sorry, my right, it might be your left, depending how you're looking at the screen, a sort of a hair on end appearance on this X-ray, and that's very typical of bone marrow expansion caused by thalassaemia. So up until very recently, our management options have been very limited. So with transfusion therapy, which is a third therapy developed for thalassaemia, but that leads to lots of complications, not just with iron chelation, but until very recently, we've had problems with the infected blood scandal and patients getting infections such as HIV and hepatitis 2. And on top of that, our other supportive measures, so calcium or vitamin D if they've got osteoporosis, vaccination, but also antibiotic prophylaxis. Stem cell transplant has been an option for patients, especially in paediatrics, and it's licensed for those who have a related sibling donor, but clearly that's not a situation that everybody has and enjoys. But more recently, we've had gene therapy and some neurotherapies too, including mitapivat, which we won't touch on here. That's hopefully coming down the pipeline as a pyruvate kinase inhibitor and helps cells to last a bit longer. But we'll come back to gene therapy in a sec. So I was thinking, especially with my adult hat on, and again, this is not with a pediatric hat, but the importance of understanding genomics and genomic testing in our thalassaemia patients. And I suppose there's a few different things here. One is that the nature of the disease and the phenotype is very heavily influenced by not just how many mutations someone might have, but also the nature of the mutation too. And the best example of that is with HBH, I think, which is very varied depending on the nature of the mutation. We know that deletional HBH, so when you have a complete loss of the alpha globin chains, actually tend to have a milder phenotype in comparison to those patients who have non-deletional. The rationale for that is that often the non-deletional mutations tend to be hemoglobin variants, which lead to very extended alpha globin chains, which tend to be unstable. These tend to have higher oxygen affinities, which reduce the O2 supply to tissues and lead to worsening this erythropoiesis in the bone marrow. On top of that, there are instances where you may inherit other hemoglobinopathies as well as a beta thalassemia gene, which can also impact their clinical course. So someone were to inherit a one copy of a beta globin thalassemia gene and one HBS, then you end up with a sickling phenotype. So we have patients who have very severe sickling who have a HBS beta 0 genotype. Similarly, we know that HBE, when inherited alongside your beta thalassemia, can actually lead to worse outcomes. On the flip side, we know that inheriting mutations in your HbF gene, so in keeping with the hereditary persistence of fetal hemoglobin, or alpha chain mutations, you can actually reduce the severity of the phenotype. Now, this is the alpha chains in particular felt because by reducing your alpha chains or a mutation that reduces them, you can reduce the imbalance. And then thirdly, you can get a co-inheritance of other genes that can impact upon disease course. This is not something we routinely test for, but I think it's fairly logical that if you have a patient who has, for instance, a mutation in your HFE genes, which may contribute to hemochromatosis, on top of having thalassemia, the iron loading will be worse. Similarly, in APE4, you may have worsened cirrhosis and cardiac outcomes compared to other of your thalassemia colleagues who do not. But I suppose the really big impact of testing and genetic testing is our gene therapy, which is something very new and something we're very excited about. And I think this diagram sort of illustrates the mechanisms by which it's produced. Gene therapy was licensed in 2024 following several trials, and the one we use at the moment uses a CRISPR-Cas9 process, and that's a process taken from bacterial cells in which you're able to cut and insert or delete various various parts of the genome that you want to target. And the target here is the BCL11A. And BCL11A is an important switch for your fetal hemoglobin. And we know actually it's very important in switching off your fetal hemoglobin when you are going from a fetus to a newborn. And that's one of the major genes responsible for that switch by 18 to 24 weeks. We know that certainly in terms of hemoglobinopathies, patients are not symptomatic in those first 18 to 24, and actually it's because they're producing a higher level of fetal hemoglobin. In beta thalassaemia, a loss of a beta globin chain wouldn't affect your fetal hemoglobin, given it's made up of alpha and gamma globin chains. So this is why it's a very useful target. So the product we have currently is called Exocel, and we've been fortunate enough we have some patients who've gone through the trials, and we're now referring some patients nationally. The next slide sort of illustrates how effective it's been. So this was taken from the New England Journal of Medicine trial, the phase 3 trial that was eventually led to it being rolled out by sort of globally, I suppose. As you can see, and I hope this projects well onto the slide. I tried to make it as big as I humanly could on the slide, but you've got 52 patients there, and the dots prior to the little red box are the number of transfusions that people have, and you can see people having transfusions incredibly frequently at this point. Then you have the treatment, and then you have the green bar, and you can see for all but 3 patients, the green bar is essentially transfusion free. So these patients were made transfusion independent. So 49 out of the 52 patients there. I think this really helps demonstrate how sort of life-changing this treatment can be. So I thought now is probably a good time to discuss our clinical case. And we were really lucky to have a patient who's involved in some of the clinical trials, who's been through this process and gave permission for us to go through a history, his experience. I understand that the transcript of his notes has been put online, but I was going to run through that now and just read from it with my own thoughts as well as I go through. So Mustafa was 4 months old when he was diagnosed with beta thal major. Now, both his parents had beta thalassaemia, which was a milder manifestation and would have been asymptomatic, meaning they had 1 copy. But at that time, there was no prenatal testing. Now, prenatal testing for sickle thalassaemia was set up in England in 2001, and it involves prenatal screening at 10 weeks. So he would have been someone who would have been picked up quite early on from this. And this is why we tend not to see so many adults coming through as new diagnoses for our clinic. We tend to see a lot of our established diagnoses from pediatrics. And the approach is basically to screen them based on either if they're in high or low prevalence areas. And that might either be through a full blood count and a HPLC, HPLC being a hemoglobin electrophoresis to help us tell what type of hemoglobins are there, plus a family origin questionnaire in those areas that are high prevalence, or in low prevalence, just a family origin questionnaire. And then depending on the finding of these results and plus or minus testing of dad as well, further testing such as amniocentesis or CVS. Now, growing up, must have thought it was quite cool that he was often missing school, and every 3 weeks he would be in and out of hospital having a blood transfusion. Now, this could be as much as 3 bags and nearly a pint, and by adulthood they are having often 2-3 pints of blood, and it would take up to about 9 hours each time, and that's really disruptive and incredibly. For a child in particular going through school, missing that much school is really, really bad. But also as an adult, we see patients really struggling to sort of keep up with employment because of the amount of time they're spending in hospital. And it also leads to them missing appointments, missing investigations, because actually, even if they have all their transfusions, they're aware their workplace may not allow them to have that much more time off, which I think is a concern, especially in our current economic climate. As well as blood transfusions every 3 weeks, Mustafa would often have nightly injections to help manage his iron overload. Now, this would be his desferrioxamine injections. This was his chelation. Desferrioxamine was the earliest chelation that we have, and this would be a subcut injection, which would be 5 to 7 days a week, often over a significant number of hours, 5, 8, maybe even 10 hours overnight, which is quite a commitment to have, or to commit to, essentially for life for these patients for iron chelation. Now, the situation has changed a little bit in the sense we do have oral iron chelators now. So we have deferriprone and most recently the Firacerox, which was licensed in 2003. But even so, as I alluded to earlier, these aren't without their side effects. And this is a medication people are often on for life. This is really, really tricky to continue with this. Now, Mustafa thought that his routine would continue all of his life, but this changed when he received a call offering him the opportunity to be involved in a clinical trial. And he was at work when he got the call, and he was told about the possibility of gene therapy treatment, and he still vividly remembers picking up the phone with his doctor at the other end. Now, what followed was a long process and many appointments where the team explained every step of the trial and the gene therapy procedure, and he underwent a full body MOT. Now, the testing even part of outside of the clinical trial is very, very extensive. So this will be patients because essentially you're giving people bone marrow transplant akin chemotherapy prior to them having gene therapy. So this would be lung function testing, it will be MRIs. Often in our patients, it often involves liver biopsies as well to try and quantify liver iron, because that can become a really complicating factor of gene therapy, especially when you're giving all the chemotherapy. Now, gene therapy, the next stage was the stem cell collection phase, and he stayed in a hotel near the hospital for 4 days and received injections twice a day to help stimulate his stem cell production. He had regular blood tests at this point, and after 4 days he was admitted to hospital where he received an injection of a drug called plerixafor. Now, this is an anti-CXCR4, and it's designed to try and, well, CXCR4 is a small molecule that helps keep all your stem cells within your bone marrow. So by opposing that, it helps to release your stem cells, allowing them for collection. Prior to plerixafor and stem cell mobilization, you'd have to collect bone marrow through bone marrow biopsies, which is uncomfortable, painful, and variable depending on technique. So this is a much better way. After this, he collected stem cells for 3 days, and that was a collection from 9 a.m. to 3 p.m. Now, this is probably a bit longer than we see in some malignant transplants and things, and that might be because actually the marrows aren't very similar, and actually it might take a lot more stimulation to get the stem cells out from people with thalassaemia, or again sickle cell, which is another condition where gene therapy has now been licensed. It wasn't until 6 months later that Mustafa was invited back for gene therapy, by which point his stem cells would have had the editing for the snipping of the BCL11 locus. Now, before being transplanted, Mustafa had to undergo 4 days of chemotherapy. This is quite hard-hitting chemo, so this would be 4 days of busulfan chemotherapy, which is what we often use for patients who have other malignant conditions. There are significant side effects to this, including neutropenia and the high infection risk, mucositis, as well as something called veno-occlusive disease, which we see a little more often we do in other patients because of the liver disease and liver iron. So something we're very careful about. Often these patients are in for a little while, and Mustafa spent 6 weeks in hospital following his treatment. And he did have a range of side effects. He had fatigue, fevers, and the worst being mucositis. Mucositis can be really, really sore and painful, and it can leave patients being able to eat or drink and actually being relying either on an NG tube or parenteral nutrition, and can take a while to go. Also, he lost his hair, which I think is actually a side effect we often overlook as clinicians, but actually is really, really important to patients as well. And he spent 6 weeks, so actually needed physiotherapy to slowly regain his strength after being in hospital for so long. He continues to attend follow-up appointments as part of his clinical trial and regular monitoring, but excitedly, he's actually no longer reliant on blood transfusions at all. And his hemoglobin levels remain stable. He feels less pain, less fatigue, and a new sense of freedom in everyday life is how he puts it, which I think is quite a nice way to end there, because it shows how important this all, what a life-changing therapy this is. And I think that's me all done.
Thank you, James. Thank you, James. That was a great introduction there to thalassemia, and obviously all these new treatments coming on. So if people do have questions, please do put your hands up, but also you can list them in the chat. We've also put a link to the patient story that James was just telling us about there, where it's listed in a bit more detail. James, can I just ask you actually that treatment that you're talking about? So is it like a one-off?
As in the gene therapy?
Mm.
Yeah. So it's a
Okay, so
one-off.
it's hoped to be lifelong.
We hope so. So the data is, we're limited by the amount of post-study data there is. So we only have about, I think, 3 or 4 years of post-trial data from gene therapy. And it is a caveat we speak to all our patients about, that we know about this lasting 3 or 4 years. We don't know 10 or 15 years down the line, will this be something that is permanent? However, there's no reason to think it isn't. And I think our thinking is that it will be lifelong.
And is it available on the NHS in the clinic, or is it still through the trial?
So it's now licensed. So it's licensed in 2024.
And is it just in certain centres though, or?
So the centres so any centre can refer. There are, the first wave of centres has gone out to people who can do it. So, for instance, I work at St George's. My local centre is Imperial, so we don't do that here ourselves. So there are limited centres that are actually doing the procedure, but any centre can refer.
Okay. Okay, grand. So I can see a hand up. I'm sorry, I can only see people's initials. So somebody called with the initials NF has a hand up. Please do go ahead and ask a question. Are people able to unmute themselves, Carmel? Yes.
Yeah, hi. I just wanted to know what is the decision point whether or not to proceed with this technique or a transplant?
Yeah, that's a really good question. So actually, I should have gone through it, but actually an exclusion criteria for starting gene therapy is actually having a matched sibling donor for a transplant. So actually a transplant would still be our first option. And the rationale for that is actually we have a lot more data about transplant. We know that transplant is something that will give you prolonged responses. Transplant itself isn't without complications, so we still have the same sort of problems with neutropenia, with mucositis, as well as infertility, which is another problem with gene therapy because of the high dose of chemotherapy, but also things like GVHD, which is you don't have with gene therapy because it's your own stem cells, whereas with your stem cell transplant you do. That said, we just have a lot more data and a lot more experience with transplants, so actually it's our first option. So if you're not eligible for a transplant, then you would be so you don't have a matched sibling donor or don't have any siblings, then you can go ahead for referral for gene therapy.
Okay.
Thanks.
So there's a question in the chat. Can the antenatal screening electrophoresis pick up a single alpha chain missing, or should it?
This is a really good question. I'm probably better aimed at people who work in sort of the hemoglobinopathy lab as opposed to myself. But generally speaking, we always have the caveat when we're reporting hemoglobinopathies. So HPLCs actually could be either iron deficiency or alpha chains. Both sort of mimic each other. I suppose the question, often the first thing to do is make sure people are iron replete before doing the test, and that often influences the HPLC plot we get. But no, I don't think it is able to pick up a single alpha chain missing.
Okay, hopefully that answers the question. I can't see everyone, so if there are other hands up, I don't know, Carmel and Lauren, if you can also just tell me if there are any other hands up.
We've had a question in the chat from Anne saying, "Can antenatal screening electrophoresis pick up?"
Oh,
no, you answered that one. Ignore me. Ignore me.
That's okay. Grant. James, can I ask you a really simplistic question? Because even in a neurology clinic, we do, full blood counts, and occasionally you see someone and they're anemic, and then you realize they've been anemic for 5 years, and then eventually they tell you they're a thalassaemia carrier, so you say, okay, fine. So obviously, carriers you wouldn't treat, but do you think there are a lot of people who might be erroneously investigated for, other causes of anemia, which could equally be avoided if you just identified they were a carrier?
Oh yeah, and quite sometimes we see they're inappropriately treated as well. So we have a number of patients who, for instance, who might have beta thal traits, whose indices can sometimes imitate iron deficiency. And the referrals we often get from primary care is there's a patient we have who's not responding at all to iron in terms of oral iron. They're very compliant, they're having it all the time, but their hemoglobin is still a bit low and they're still microcytic. Can they have an iron infusion? And actually the answer is no, because they've got beta thalassemia trait and actually they don't need any more iron. They're okay. But it's, yeah, I think there are examples where that happens.
So again, so I did a quick bit of homework before this. So obviously, you know, it's looking at your ferritin levels and your iron saturation and so on is meant to help guide you whether this is an iron deficiency anemia or a thalassemia. Is that correct?
Yes.
But again, do you think, I mean, A, is it done, and B, how good do you think that is at really identifying?
I think if you've got low iron indices, it's very good at picking up iron deficiency. So if you've got a low ferritin and low TSATs, I think sometimes it's not very easy to pick up when people don't have other conditions that might influence your ferritin and cause a low hemoglobin. Sometimes not as clear cut as that. But we certainly do see people who are perhaps misdiagnosed as something or other, and actually having a thalassemia trait might be influencing there. I mean, we also have patients, it goes the other way too. So we have patients who might have a thalassemia trait who actually have a worse anemia than you would expect, and actually it might be something else going on as opposed to just the beta thal trait, for instance.
So if we had someone who had a microcytic anemia, but actually you measure their ferritin and it's normal, should you be considering thalassemia testing?
Yeah, potentially. I mean, often, and I think it's easier when I've seen lots of them, but often there's a big so especially with the thalassemic indices, there's a really big discrepancy between the level of anemia that you might see and the level of microcytosis. So you might see a much greater difference. So you might see someone who has a hemoglobin 110 but an MCV of in the 60s, which is quite a big difference to where you normally see an MCV of 70 and a HB of 90 and a true iron deficiency. That's not a rule, it's just sort of a feel for the blood test, I suppose. But I suppose, yeah, if you've got a patient who's got a microcytosis, who's iron replete, then yeah, the question is, is there a thalassemic indices there?
Okay, brilliant. I think there was a question right at the start. Love the slides and the infographics, but can I ask, is there any recent data? I think that was right at the beginning when you were talking maybe about prevalence rates and different geographical locations.
Oh, I don't know about if there's any more up to date, partly because it's quite difficult now to track. Given how people are more freely migrating between areas, it's very difficult to know. I'd have to do some research about that, but I don't have anything to hand.
Do you think with the antenatal screening now, the prevalence rates go up now that there's more testing?
Do I think they're going up? I mean, it's probably a question for my paediatric colleagues, because they're the ones who see them probably most antenatally. We're seeing sort of the 18 plus, sort of beyond 18. I would say probably not of the severes, because I think the severes would present anyway. You might be picking up more patients who know they're likely to be a trait carrier, and people knowing they're more trait carriers because of it. In terms of this more severe phenotypes, the chances are you're going to know that you have a more severe phenotype before you're tested.
Okay. Lovely. So I think Carmel has just sent around the poll again. We just did a pre and post poll. Hopefully that comes to you. Okay, just any last final questions? Otherwise, I think ready, just about to wrap up. So thank you so much, James. I learned quite a lot there today. It was very good. So as I say, if we also happy to share the slides. So if you want any of the resources as well, the educational resources, please do just let us know. We can share that with you. And as I say, if there are any departments or teams that would like the education team to go through the genetic testing, the logistics of that in a bit more detail at a slower pace, please do get in touch with us, because we're happy to come and speak to teams about that as well. Otherwise, I hope you enjoyed it. So thank you very much for joining us, and we'll let you leave a few minutes early. All right, lovely. Thank you, James. Nice to see everyone.